All right, can everybody hear me? Yeah, I'm hoping online can as well. So good day, everybody. Thanks for joining. I'm Jay Krishnaswamy. I'm the current president of the Association for Academic Global Surgery. I'm a pediatric surgeon, and I'm in children's surgical services at Oregon Health and Science University in Portland, Oregon. So welcome, and thanks to very much to the West African College for being our gracious host for this and allowing us to have our joint session with all of you. I want to also have my co-moderator.
So my name is Yama Joy. I'm a general surgeon. I work at
All right, so today we're going to be going through this agenda that's here. I'll start off introducing the AAGS, which is the Association for Academic Global Surgery, our purpose, our structure, our recent work, and then I'll give a little overview on collaborations, and we'll jump into what should be hopefully an exciting and kind of engaging session on initiating, developing, and maintaining bi-directional equitable partnerships. We have a distinguished panel of both HIC surgeons and West African surgeons here who are going to enlighten us today with their discussion. Okay, let me first start off by defining what is academic global surgery. So we define this at the AAGS as the application of research, education, and evidence-based advocacy towards clinical surgical care in regions of health and equity. The primary goal in the field is really infrastructure development with delivery of high-quality surgical care for all, regardless of geographic or economic boundaries. Therein, the purpose of the organization is to serve as an umbrella for our field, promoting academic principles within global surgery, organizing and cultivating academic global surgery programs from all sides, fostering bi-directional partnerships, advancing the importance and the visibility of this field, and developing the next generation of global surgery leaders. We currently have 5 membership categories that are intended to span the range of involvement for those in academic global surgery. For more information on joining the AAGS, you can scan that QR code or enter the bit.ly address that's shown on the screen. So our members come from 45 countries. That's all shown in blue here. 28 of the countries represented are LIC or LMIC, and 17 of which are high-income countries or upper middle-income countries. The membership breakdown by category shown here. While we are diverse geographically as well as by gender and some other metrics, we are actively seeking out passionate colleagues from LMIC to join committees and, more importantly, organizational leadership. While our first members, and their programs were from North America, the aim has always been from the beginning to have it be a global entity. We really want to engage LMIC members and surgeons. Listed here are the committees that really do the work of the organization. All these members and committees will be done. I want to take a few minutes to discuss organizational progress toward our goals that I stated earlier. So the AAGS had its origins in 2017 when the need for a formal umbrella organization for academic global surgery dedicated to the field was discussed. In 2019, we adopted our official name and created an initial draft of the Constitution. During COVID, we spent time really creating the structure and real bones of the organization with the creation of our committees and formal election of the inaugural executive council. As a new organization, we've been further developing and evolving over the last few years. In rapidly emerging from COVID, we set out with our committee leaders to develop our strategic plan as an organization with the support of Operation Smile and under direction of Circle International. We identified some short and long-term goals of the organization and ultimately, and for each committee. And ultimately, this led to each committee identifying existing gaps in their area, both within global surgery as a whole and within the organization itself. These then informed our 1 to 3 year goals of each committee. In addition to the overarching goals of each committee, which you can view by again scanning that QR code with your phone or entering that bit.ly address, which takes you to the actual gaps and goals of each committee. There have been ongoing efforts in everything from a formal accreditation structure for global surgery programs in order to the short common standards, which we hope to roll out later this year with for public comments before finalizing. The publication of consensus statements on conference equity to benefit participants worldwide, to a centralized fair where global surgery programs can reach out to prospective participants. As part of our mission, AAGS has formed partnerships with Decision, which has led to collaborations with trainees around the world on a host of events. Additionally, we joined the G4 Alliance for Surgery, Obstetrics, Trauma, and Anesthesia, and made many other connections within the global surgery world. We're very excited about our latest collaboration with the Journal of Global Surgery. And this is really a groundbreaking peer-reviewed journal dedicated to global surgery that's powered by actually Bitcoin. Their business model produces a very low cost, high quality, open access journal that's sustainable, accessible, and affordable, and then meets the needs of the entire global surgery committee. So please consider submitting your work to this emerging entity. We really hope that it'll help leapfrog accessibility and affordability in the dissemination of global surgery research. As we've been making these organizational connections, our members have been taking the work of the organizations worldwide to conferences like the Consortium of Universities in Global Health, where we've had presentations on global surgery and the role of the organization, as well as more specific topics within other surgical societies around the globe. In 2022, we held our first large virtual assembly with 6 LMIC and 6 HIC speakers on leveraging academic collaborations for surgical systems strengthening. We had a diverse audience with about 200 registrants from 31 countries, half of whom were trainees or non-MDs. And then subsequent to that, we held our first in-person and virtual, so hybrid event on global surgery education in the fall of 22, which had registrants from 36 countries. We featured panel discussions and presentations by stakeholders kind of across the field, from physicians to nurses to engineers to epidemiologists. The assembly also launched our first ever scientific program. We had 13 oral research presentations from 9 countries, 6 of whom were from LMIC. All of us interacted with each other in a pretty exciting session. I was just mentioning earlier that probably one of the coolest moments I've had in global surgery was a moment where we were in the US and we had somebody presenting a abstract from Pakistan, and somebody from Nigeria was commenting on it along with the person in the room in the US. And so it really connected all of us very quickly. At the time, we also announced our plan to move our yearly assemblies to rotate across continents with continued hybrid offerings and the goal of diversifying our committee and organizational leadership towards a balance of LMIC and HIC that reflects our membership. And then at the American College of Surgeons meeting 4 months ago, we held an informational and interactive meeting of the organization where the committees that are listed here presented their work to prospective members. It was very successful with about 150 registrants from almost 40 countries and many dozen more joining in person to discuss ideas and obstacles and opportunities in academic global strategy. Again, kind of an enthusiastic and spirited discussion. We had in person as well as online. More recently, through the efforts of our advocacy and research committees, we contribute to the NIH request for information on promoting equity in global health research. There will soon be a published version of our commentary in addition to this public report. Something exciting that we're particularly enthusiastic about is that we've recently launched is the AAGS Academic Global Survey Virtual Seminar Series. The idea here is that the AAGS facilitates organizations and institutions and programs to come together and share joint material on a bi-monthly basis that's of relevance and utility to all of us in global surgery. For example, we have planned organizations in Africa, Asia, South America, and elsewhere working together to deliver content to a global audience. Hopefully they're breaking down those physical and intellectual silos. The series has been in the form of panel presentations, case discussions, workshops, perhaps even culminating into a global M&M conference of sorts. We held our first successful seminar series in September of last year, and then the second in December of 2023. So stay tuned for some exciting content and that should be coming out soon in this realm. Looking forward, we want to promote even more LMIC involvement in the voice and the business of the organization through the various avenues that I've mentioned, with the goal of at least 50% of the leadership, including the executive council, being from LMIC by the end of 2025. And we're well on our way towards that. We'll also continue to further our strategic plan with the advancement of our self-identified committee goals and cross-committee and cross-organizational work while furthering our external partnerships. So I'll turn a little bit and I'm excited to introduce our inaugural Operation Smile AAGS Travel Scholar. So in keeping with the core missions of what I was just talking about to foster greater global surgery interconnectedness and collaborations, we initiated a scholarship program just this year through the generous support of Operation Smile that brings the winning abstract from our yearly worldwide scientific program to the next AAGS international event. This is going to be an annual scholarship rotating amongst organizations where we hold the international sessions. And it's going to allow us to promote a united community in academic global surgery. We're very excited to have launched that program and our inaugural travel scholar here at the West African College. Towards that, I want to introduce this year's winner. In December of 2023, Dr. Sadeh Shadeh presented the winning abstract on population level cesarean section rates in India. Dr. Zadeh is a co-founding director of the nonprofit Association for Socially Applicable Research based in India and a doctoral student in epidemiology. He also leads the Global Surgery Group at Gemini Research Center, where he focuses on mapping surgical care indicators for low and middle income countries with a special focus on South Asia. He's previously worked on building low-cost gasless laparoscopes useful for improving surgical care and its access in resource-constrained settings. His advocacy work focuses on highlighting issues of surgical disparities in policy, and currently he serves as the chair of the Surgical Care in South Asia Working Group of the G4 Alliance, and as a fellow in the Lancet Citizens Commission for Reimagining India's Health System. He's traveled here to West Africa to collaborate and to make connections with WACS members and to help further engage the WACS with potential members, collaborators, and organizations worldwide through the AAGS. So congratulations, Dr. Today.
Yeah, I think I'll just start. Thank you so much for having me. Thanks to AAGS, to WACS, and to Operations Mind for inviting me. I'll maybe take like 2 minutes to talk a little bit about where I come from, the kind of work that we do, and why I feel like it's so crucial for young trainees like me to be in places like this. So I started working in global surgery about 6 years ago as part of my master's program. And I was trying to map out Lancet Commission surgical care indicators for India. This was not done before. I was particularly interested in rural India and looking at utilization, access, and financial burden. Right. Since then, I went back and with my wife and a bunch of our friends, we started a research and policy group called Association for Socially Applicable Research, ASR, which also translates to impact in Hindi, which is our native language. So, and a lot of work that we have done in past 4 years or so has focused on using what we like to call scrappy data science. So we work with a lot of local data, which tends to be incomplete, sometimes of low quality, but we are trying to extract maximum possible information from that. We are trying to learn from local context. We are trying to learn from lived experience of people, of providers, surgeons, and we are trying to put all of that together for systemic and sustained change in terms of strengthening research and having effective policies. Last year, I also got an opportunity to work with teams doing similar kind of work in Tanzania and in Burundi, where we did a lot of work in pediatric surgery. And one of the most massive learnings in that experience was that West Africa, Sub-Saharan Africa, South Asia, we do share a lot of problems, especially when it comes to access to surgery. And so that kind of just means that we also must share our solutions. So yeah, I'm happy to be here, and I look forward to interacting with all of you to learn from you and to figure out how we can work together and collaborate to actually share some of those solutions. Again, thanks to AAGS and Operations Mind and to WACS for having me. Thanks so much.
Okay, so with that, I'd like to turn our attention toward the main goal of today's session, which is to discuss bidirectional equitable collaborations in global surgery. I'll just frame it a little bit by saying that when we look over the last several decades, we know that there's been this market transition in the structure of global surgery collaborations from short-term volunteerism towards sustainably expanding the breadth of partnerships beyond purely clinical towards education and investigation with an eye towards equity. To continue the growth of the field, we must obviously focus on how we can expand in a bidirectional manner, benefiting both the HIC and the LMIC partners. Frameworks to achieve this have been suggested, focusing on themes of sensitivity and appropriate leadership and understanding of local needs within a structure that again emphasizes sustainability. But how are we doing towards these ideas in this field currently? What has been the evaluation of these efforts? We recently published a survey distributed to LMIC Surgical Society representatives from multiple regions of the world, which assessed nature, perception, benefits of collaborations, and issues of communication. We received responses from about 15 LMIC countries across 3 continents and 6 different surgical and allied specialties. more than 90% of whom had participated in partnerships within the last 5 years. We found that most interactions occurred on an occasional basis, and again, these are LMIC respondents with this. It's not HIC people stating everything from here on in. We found that most of the interactions occurred really on an occasional basis, with about a half of these being scheduled on a regular cadence. More than a third were now utilizing virtual means for these interactions, especially over the last couple of years emerging from COVID. As far as regions of the world, for the HIC partner, it's been, not surprisingly, pretty evenly split between Europe and North America. And 3/4 of surgeons who responded LMIC respondents said that 3/4 of their HIC partners were involved in operating when visiting their LMIC partners. And while the vast majority participate in non-clinical education activities such as lectures, under 2/3 were perceived by the LMIC respondents as participating in perioperative. When LMIC partners were asked to rank what type of collaboration was the most valuable, clinical partnerships directly related to patient care were ranked number 1, followed closely by education. However, when LMIC partners were asked to rank what type of collaboration is the most sustainable, at least in its current form, clinical partnerships were deemed the least sustainable. The reasons for this are perhaps underscored in LMIC perceptions around communication. Whereas even though 72% of the HIC surgeons operated, as I said earlier, from the LMIC perspective, only 40% really understood the operating environment reasonably well on their arrival to their partners. While 3/4 of LMIC partners did have the opportunity to express their needs to their HIC partners before they first arrived, more than half the time, the LMIC partners were the ones to initiate that conversation. In all, less than half of the HIC surgeons were felt to adequately understand the overall environment at the initiation of collaboration. So clearly an issue. Overall, from the perception of the LMIC partners, collaborators are increasingly diverse in geography and scope, and in addition to research and education, there remains a real need and perceived benefit in sustainable clinical partnerships. Most HIC partners are operating, but many are not perceived to be involved in post-operative care. And independent of region, most of the respondents reported inadequate structure of the collaboration, especially in its initial stages. So with all that in mind, we want to turn now to our distinguished panel, so we can discuss the kind of ins and outs of initiating collaborations and hopefully learn some pearls of what to and what not to do.
Right, so I'd like to introduce the panel for this morning. We are going to have a series of panels, and for the very first one, we are joined by Professor T.B. Kamara, who is the chair of the AAGS Local Organizing Committee, and Professor of Urology at the University of multiple content. Please, please. Next in line is Chino Fuki with Professor of Neurosurgery at the College of Medicine, University of Nigeria. Next is our very own Ben Woman, Professor of Surgery and Pediatric Surgery, Director at Nationwide Children's Hospital, Ohio State University. Last but not least, Great Rice, Robert Matheson, endowed Professor of Surgery and founder of the Center for Global Surgery at the University of Utah University. So let's jump right in. So the questions I have are rather directed at specific individuals, and we'd like to go straight ahead and ask the first question go to Dr. Price and Dr. Luce. In your opinion, What are the foundational elements required for achieving sustainable global surgery collaborations, and how can tandem growth be fostered from the very onset? So I think Dr. J and Dr. Price, please.
Good morning, distinguished audience, and thanks for having me. I'd like to start by saying that bidirectional collaborations, I like to describe it as a two-way traffic in the global surgery market that leads to beneficial symbiotic relationships among centers that are willing to collaborate with the high-income countries and the low and middle-income countries. Now, to initiate the bidirectional collaboration, one of the key steps is designing what I call the need map, need assessment, both for the low and middle-income countries, for the high-income countries. Because there's a reason that we want to collaborate. And that need assessment is very important for contextually appropriate and beneficial offerings to be initiated and sustained. It's also important to identify the drivers of disparities and inequities in the recipient field that are responsible for the gaps in care, quality, and access. That is very important, and it's better that this needs assessment and the drivers be identified and perhaps discussed or published by the recipient. And then lastly, I would like to say that for contextually appropriate interventions to be initiated and sustained, we need to prioritize the process in terms of identifying what comes first and what should follow, especially with respect to the size of the need and the gap that we're hoping to resolve. Thank you very much.
I'm glad you used the word willing. Yeah, okay, so that's correct. Let me say it.
No, I agree with everything you said. I think those like could probably not say anything, but I think what I would add is to do all that is even a little bit before that. How do you build the trust between the organizations that you're working together? How does your partner develop trust in you? How do you develop trust in your partner? And I think those kinds of things are extremely important. I think part of it is developing relationships and developing friendships that allow you to really develop the programs that can have the most benefit and over time. And I think that takes time. So often I see something that's, let's do this project and jump in and let's get going. And yet nobody knows each other. And I think creating relationships for trust is one of the biggest things to initiate a new project.
Right, so we've got two words here. We've got willingness and trust. The next set is going to Dr. Kamara and to Dr. Mohammed. How do you decide on which method of engagement to utilize? You've got to decide on which method of engagement to utilize.
Thank you very much. Good morning. It's a difficult question to ask because I remember our first engagement started after a conference like this in 2008, when we came across surgeons overseas. They came here to conduct a pre-conference workshop, and they stayed on and listened to the presentations. After that, they engaged me and others. And what we started first was a research on the needs assessment of the surgical zone of the country. And we published papers on that. And after that, we also looked at the human resource. At that time, we had only 10 surgeons in the country, and over half of them were approaching retirement age, and there was no postgraduate residency training program in place. So we took time to look at all these needs and started with the issue of training. They sponsored our training and encouraged, and it was very difficult. We had to pay the residents a bribe, quote unquote, them to attend classes, revision classes, and even to register for the exams. Today, I'm happy to say that that has paid off well. We have over 20 residents in training in various surgical specialties. So I think the issue of choice, well, you choose for yourself. But for us, we took first training, and during that time, they also helped us with consumables. Because at that time, we didn't have things like sutures, gauze, or even plaster to dress wounds, and all of those things have helped us.
Right. So I think my message from here is there are a lot of cultural nuances, the one must visit cultural nuances.
Yes, I think I will emphasize what TB just said, and actually amplify what my colleague Enoch said earlier on the theme of needs assessment, because I think you can apply the concept of needs assessment even in answering that question. So, what do our partners need? Because I think we can build the answer to that question. What do they need? Is the need greater in the clinical realm, or is it greater in the research realm, or in the training and education, or even advocacy? Do they need our help engaging their leaders to advocate for greater resources? Is that their greatest need at that point in time? I can never forget a meeting that I had with the dean of Addis Ababa University when I, in my attempt to perform that needs assessment on one individual, I posed that question to him, and I said, what do you need from us as potential partners? Do you want us to bring surgeons to your institution? Do you want to take your residents to my institution for clinical rotation? And he said, no, please don't do that. Because if you did that, residents would never come back, right? And he said that his greatest need was for teachers. He pleaded with me to bring myself and my faculty to his institution to serve as external examiners and to provide lectures. And that was his greatest need. And when I posed that question to another leader in another institution at University of Cape Town, I got a completely different answer. So I think that, as TB said, that the answer to that question is contextual. Thank you.
All right. So just hang on to that. Let me just ask one more. What have you found most effective? You seem to have answered it already. What have you found most effective in establishing some collaboration?
I think what I have found most effective is to do the needs assessment, identify what is meaningful to the local partners, and then work with them to deliver that need.
Maybe, how about you?
Yeah, thank you once more. I just want to add that you presented a slide earlier on and stated that clinical and support is the least sustainable. Then here gave us trunks of textbooks, of surgical textbooks. I don't know if you remember, and he took them to Liberia, at a wax conference like this. Gave them to me, and I brought them over. They are still being used at Connaught Hospital, the main teaching hospital. So that is sustainable. they are there, and we, for us, the most sustainable thing is local training. We don't want our people to go out, but because even when they go to Ghana, as I'm talking to you, 5 of our trainees are there. They are serving Ghana instead of coming back to Sierra Leone. So we want them to train there. If they are going to train at all, let them do 3 months, 6 months and go back. The longer they stay, the more difficult it is to block them, to bring them here. So that is my view. Thank you.
We love them. We love them.
So, thanks for all your comments. You know, I mentioned earlier that some surgeons in LMIC feel as if their HHC partners don't understand the environment, that they're maybe a little disengaged with peri-op care, and in some cases, may even be overzealous. Some have referred to this negative aspect of collaborations as neo-colonialism, and that brings the idea of, you mentioned a little earlier, that the problem here may be grounded in a lack of mutual understanding of not just the resources, but also the medical and social, cultural and context within what we each work in. So towards that effect, and this is for Dr. Price and Dr. Cameron, how can we ensure cultural competency and effective communication in those critical initial stages of global surgery partnerships, considering those diverse healthcare practices and social beliefs that we all hold?
You know, think about that question. You said, how do you ensure? My simple answer is you can't ensure. But what can you do to try to make that happen? And because people come from all sorts of backgrounds, you say the bilateral. What are the considerations for your partner where you're working if it's outside your country? What is your consideration for partners that are coming from another country? Understanding that there are limitations and there are things on both sides. I get back to how do you really ensure that? I should have been an anthropologist because what I love is learning about people. I love learning about cultures. I love learning about how they interact. And that helps in developing these bilateral partnerships. It's not just about, let's come and do some research project. What is really the underlying desire of both institutions, understanding bilaterality, but then really creating an understanding of where you're working and who you're working with, what country they may be coming from. Do they really understand where Kirsten's coming from? What's her background? Do they understand what TV's background is? And then the history that's here in Sierra Leone in the background. And I think working with our trainees and trying to bring the next generation of global surgery leaders up from around the world, because global surgery happens in these countries. Up in Kumasi, APRODEC goes up to the north twice a year to do an outreach program. Do they understand the local concerns, even of the outer areas that they're going to? So, what would you like to say?
Thank you. The thing to note here is that for our own context, there are 2 sides coin. You have the academics and you have the administrations. The administration carries the power, the Ministry of Health. We can do all we want to do. If they don't support us, we won't move. So that is why we need to put everything on the table and explain, especially for them. For us, we know already our needs, what we want, what we are aiming at. But for them, it may be a little bit difficult. And that is why I remember my US friends, we used to go to the MOE, the Ministry of Health, to hold meetings. Nearly every week we go to a meeting. We are outside meetings. So I beg of you, please don't be tired. Let's continue to attend meetings. And they saw it when they sent containers, goods for us. When the ministry did not participate in clearing them from the port, they had to come to Sierra Leone. You see, what a big loss. They had to pay to come and help to take them out. If the ministry was involved, of course, they wouldn't have. So this is what we have to keep in mind also.
Right, so my next set goes to Dr. Uche for Kuno. Now, in your view, you're talking about bidirectionality, and in your view, what are the key components of the truly bidirectional partnership in global setting? How can these be implemented right from the very beginning?
There was some kind of screen. I think that, both parties have to be involved, in, the planning, right from the beginning. Both parties have to be involved in articulating, the mutual goals, in the planning and in the implementation. Planning for the evaluation and the accountability. And I think both parties have to be involved right from the beginning. I think that is going to be the key to success.
May I switch the question a little to say, can you tell us what you think are the advantages to each type of visit, and if you've had any experiences with a lack of bidirectionality and what effects they brings the academic project you've been involved?
Thank you very much. Well, I'd like to confess that actually I've been working with the Swedish African Neurosurgery Collaboration. In 2018, we set up this neurosurgery, global neurosurgery consortium that has been going around West Africa trying to offer neurosurgery help to different countries. And actually, the SANC was a child that came out of a failed collaboration. In 2017, I was to collaborate with a group from the US. And what happened was that there was a middleman. The middleman drove a wedge between us because it was difficult to communicate with collaborators from the United States without having to go through it. And because of that, because there was no common place to discuss, we had to go through middlemen to communicate. That could not succeed. And so from that experience, we now set out to try something where at the outset, the collaborating units came to the town hall and brought perspectives and contexts from both environments. And then we identified what we call low-hanging fruits from our local environment that was going to be the area that we were going to find the most benefit. And then we applied those low-hanging fruits. And that's why we have SANC, because there were a lot of contextual differences, things that were allowable in Sweden that were not allowable in our environment. And things, for instance, the Swedish Neurosurgery Collaboration Society said, look, we can't need surgeries in West Africa. So for every of the surgeries that we do, you have to be responsible. We will assist, but we will not need surgeries. Because it will be difficult to ethically handle it in our environment, in our context, if there were issues. And so because of that, we have to discuss every case and be sure that we are able to accept the complications and the problems that we call. Secondly, we need to understand your context, your culture, and your social environment. And so I have to travel to Sweden to go and discuss the prospects and challenges of neurosurgery in Africa, using my own environment as the context. It was a 3-hour presentation. The whole University of Uppsala, they gathered with some other subjects from Karolinska, other places. And for 3 hours, I was mapping the social, cultural, political environment of my context. And there were a lot of questions. It was after that we now had to look at forming a memorandum of understanding based on the understanding of the context I have presented. And then we began to prioritize based on the need map that I had presented, the areas of need and how to roll out the collaboration. And today, that collaboration has gone to about 5 countries, and as continues to, in fact, this year we're collaborating with WAPS and performed the first set of endoscopic brain surgery in this country. So I think to answer that question is that there has to be continuing communication. There has to be an understanding of rules, shared rules, and then I'll add finally, there has to be continuous audit of what is being done, because the need map changes. And that, we have come to understand that by the time you roll out your global surgery offerings, you have to audit, because over time the need changes or is modified because of the intervention, and then you can be able to assess your impact and also see where else to look at. I think that those are the things I want to point out. Thank you.
Thank you so much for those comments. So last question for this section. This is for Dr. Price and Dr. Womack. How can global surgery collaborations, I think in surgery as in life and medicine as in life, there are a lot of dynamics, and how therein, especially when you're initiating a collaboration, can these be structured to mitigate these balances? And how do you, kind of address them upfront to hopefully promote equitable contributions?
Probably the one of the most important ways that the power dynamics can change really is for global surgery to, I think a lot of global surgery, the way we kind of imagine it these days, tends to be what the global north does to the global south. And I think when I hear, my brother, Dr. Uche speak, many of us are beginning to understand that there is actually global surgery happening from intervention happening from the global south to the global south, right? Here is a very highly skilled neurosurgeon from the global south, from West Africa, taking his skills across the West African sub-region. He has taken his skills, very highly specialized skills, to several West African countries. In many cases, these West African countries are having a neurosurgeon operate in their country for the very first time ever. So I think the more that this happens, this power dynamic will shift in a very fundamental way. So, I think that this is going to be a huge paradigm shift in that power dynamics, the more that this happens. Thank you.
Yeah, I agree with you, Ben. Where do the power dynamics come from? Historical, maybe background. It comes from who's funding whatever the project is. And I think in many of the things, those power dynamics are there. The real question is, how do we mitigate those kinds of challenges while we're working on it? So on many projects that I have done, in terms of setting up laparoscopy for the whole country of Mongolia, that was funded by multiple organizations. So when we talk about partnerships, the partnership with the University of Mongolia, it's a partnership with other funders, there was a partnership, it was a consortium. And there are different power dynamics. The companies that were donating the equipment, they had power. And I think it's how do we mitigate and still work as setting up an equal relationship, recognizing that there are historical things, there are financial things, there are social things that create some of these challenges. That again, I should have been an anthropologist. I think, how do we work together to really be friends and understand what each person is doing? I too believe that, and you see so many of these south to south projects, but even if it's a south to south project in the States, when we do a project in the States, there are power dynamics. And so how do you mitigate those? I think is the real issue.
Great, maybe we can give that hand to our panel. And we'll move on to the next panel, which is developing big collaboration.
Okay, so we'll just move straight on, and I'd like to introduce the second panel. Dr. Oluwole Olaomi, Nigeria, is a consultant general surgeon and chief of trauma surgery in the National Hospital of Nigeria. He's in there. And you might see Olakide, consultant pediatric surgeon, Lagos University Teaching Hospital, known to me as Bridge, in Nigeria. I can't find anything in action. But Jonathan is supposed to be here. Jonathan Lai, President Chief of Colorectal Surgery at the University of Arkansas of the US. And lastly, Surgeon in Chief at Nationwide Children's Hospital, Columbus, Ohio. Yeah. Oh, okay. So Peter is going to fill in for Jonathan. It means Peter is going to do 2 sessions. It's okay. It's perfectly. So may I introduce Peter Eke, Professor of Surgery, Director of Acute Care Surgery, Medical Director of Trauma, Miami Valley Hospital, Wright State University, Dayton, Ohio, USA. Thank you.
Thank you all so much, and I'll just briefly introduce myself. My name is Kristen Long. I'm an endocrine surgeon at the University of Wisconsin, and I'm privileged to be involved with the AAGS as the Vice President of Strategy is my usual role. So we will start with this distinguished panel with our first question. Mainly looking at how we identify and prioritize interests. So how did you decide what was the primary interest point or point of collaboration for your partnerships? And if you had more than one, how did you decide which to tackle first?
The question goes to Dr. Olakide and Peter.
Thank you.
Thank you very much, and thank you for the opportunity to speak here. I think I would say for me personally was based on what was reminding that at that particular point in time. And I know we speak about needs a lot. So basically, I was informed, the areas that were my initial points of interest for collaboration. Yes, I had several areas where we had needs, but then ultimately focused on what was sustainable. And of course, sustainability, as we talked about, so I will focus on that, and feasibility, really feasible, right, for developing collaboration between my center, which is in the global south, and with colleagues in the global north. And so much of our collaboration has been focused on research. And so for the other areas like for clinical skills acquisition, I would say that much of my areas of collaboration has been south to south. For example, I had my training in Equitable Teaching Hospital, where I also had some collaboration with colleagues there, and then also looking at colleagues in the country to help develop the skills. But for global north to global south, we focus mainly on research, and that was based on both sustainable and feasible to do. Thank you.
So when we talk about identifying needs, that's an interesting question. I think that, as has been mentioned already, and is always identified in public health, you always think, what do the people need, and what do they express, the people you're trying to work with, from the high income countries to the LICs. And so that's really important. But I think on the other hand, there are sometimes, and this may sound paternalistic or being, there are needs you can see that exist, and people may not necessarily realize that those needs are there. And I think in that case, it's just finding the right partners who you can work together. I mean, I can say a practical example, Dr. Olaomi right here has a great interest in trauma. He's doing a lot of great work. And I have found a person that I can relate to very easily because he very clearly expresses what is needed. And kind of, we have an alignment in the way we see things. So I think the partnership is important. So I think the most important thing is listening to what people have said that they need. And they talked earlier about understanding culture and all that. You know, even there are times when you see some glaring things that are needed, but you have to use wisdom on how you apply or how you move. Sometimes you can't move too fast. You have to sometimes help them understand and see why this is necessary.
Thank you, guys. That's very insightful. The second question that I have is really about setting mutual goals and expectations. I think that it can be very difficult, and how do you have mutual goals and expectations be effectively set and communicated amongst all your partners to ensure a successful collaboration? And probably more interesting, can you guys give us some examples of some mismatched expectations that you may have encountered? And this question is for Dr. Olatuye and Milan.
Thank you. Great to be here. I think as we've heard from the first session too, it's important for there to be alignment, and alignment of goals is a critical aspect of this. And when you talk about goals, when we talk about short, medium, and long-term goals, first of all, what's the pie in the sky? What's the ultimate goal that you hope to achieve? And I think that needs to be aligned from the very once, realizing that your accomplishment of short-term goals have to be along the path of meeting the long-term goals. Classic example is the overall long-term goal may be, but that should be building capacity. I feel as our work is in global health and global surgery, the measure of success is when we're no longer able to be able to build enough capacity, and we don't need to go back there because we've built a sustainable environment. And that should really be the ultimate goal. Now, to get there, maybe the initial aspect of really providing clinical care, starting with the teaching, building the pipeline and all that, so you can set those, articulate those goals. But those should not be top-down goals. They should be goals from the global north to the global south. They should be mutually crafted, mutually understood goals. And also, again, they should be smart goals, right? Not those goals that, oh, one day when the stars come down, we'll be able to do X, Y, Z. But to actually make them specific, measurable, and attainable goals that you can actually be on a time specific, realizing that the time factor can have to be adjustable based on the criteria. But the goals have to be set short, medium, and long-term goals. But then in terms of example, there are times that you may go into an area and think, oh, this is what they need. Or, you don't need laparoscopy. You should start off with the basic stuff. But if you feel that that's what's needed in that environment, to actually get the people working back to the farms and back to general activities soon. So you can come with your goals. They have to be mutually acceptable and achieve goals set by both sides in collaboration.
Thank you for having me. Collaboration is a form of project management. And we need to look at the 3 P's of the project management in everything we do. The people, the process, and the platform. And the most difficult of all this is the people. Me and you, the way we perceive things. So in setting mutual goals and expectations, we need to be open. It has to be open discussion. We bring everything down to the table so that we can talk about it from onset, move together with it, agree on our expectations, and then set the timelines so that we can assess, are we moving together or we're not moving together. And that will also help us to see the area of conflicts right from the beginning. Before conflicts, we already know these are the areas that we're likely to have conflicts, and we'll avoid those areas. So we need to be on the table. we need to be open about it. Anything we want to do, bring it down to the table, discuss it, look at it, the pros and cons of it, and then ask questions, because when you're discussing it openly, then you need to ask questions. Why do you want us to go this route? When do you want us to achieve this? How do we achieve it in your country, in your area, in your institution? These are the difficult part of it, and we need to put it together. We heard from Kamara, it's not just the clinicals, what of the ministry? Because these are things we need to put down. If you need to have counterpart funding, how do we get it? Who provides what for what? And how do we see that this is done? So these are very important things in setting those goals. We may need to modify at that point in time. And it's not about our ego, because that's what I found out at times when people have to set goals, expectations that they're bringing it. And if you're not going to follow that plan, it's not going to work for them. It doesn't work anywhere that way. Thank you.
Maybe you should still hang on to the mic. How do you get local buy-in, not like Madam? How do you get local buy-in? How do you garner the support of resources to push partnership forward? How do you get it?
Now, again, just like what I said, the people, who are we dealing with? The people. I'll give an example. For one of the AAGS meeting in Abuja, data is a problem all over, everywhere. Let me not just say in Africa, but at least in Africa, we know that we have issues with getting data. And so we met with a small group and decided to do a small project on trauma registry. There were two people then, myself, Professor Emmanuel Habe from another institution, then we gather with, I think it's Laura. And then we had a small, just very small data sets and see, we put it on RedCap, and the two of us there were able to do that. Then following other meetings, crash two programs and things, we gather people working in trauma and say, look, we have this small thing and we want everybody to be involved in it. Let's get the Nigerian trauma registry and with these small sets. And everybody agreed. But it was only the two people that initiated it that entered data after 3 years. Despite we had all sorts of meetings on the Crash 2 program, nobody else entered that because they were not able to trust us with their data. Despite the fact that we told them, we won't have access to your data. You can have access to your data. So you need people to trust you. And I think that's the main thing when you want people to buy in. People must trust you, people must believe in you, and people, you need to be friends with them and develop that trust. It is not that day that they will trust you. That's it. Then you need champions. For National Hospital, that was fine. We wanted it. But we brought in Amen, who was a champion then for ABU, Zaria. And that worked well. But it didn't work well with other people because they didn't just believe in our dreams. So you need champions, you need opinion leaders who will understand what you are doing and will be able to help you to gather resources around you to get these things done. There's another example I will give. We run in the trauma center an annual trauma, a week of annual trauma series, lectures, advocacy, and things. And it worked well for us for 4 years because the chief executive believed in us. Immediately the chief executive changed. We lost that. Nobody was going to fund it. In fact, we're going to struggle with the halls we use. The official backing for invitation to all other institutions, we lost it. So we need people at that level who believe in our cause, who want to institutionalize whatever we're doing, and it should not depend on individuals. And I think that is the major problem we have with projects. It depends on individual, and one visionary dies or leaves, the project also goes down with it. So we need to find ways to get to institutionalize projects and collaborations that it does not depend on individuals. Thank you.
Thank you. Madam, do you have anything to add?
Well, I'm just a summary of what just said. It's basically identifying like-minded individuals, and that's usually from long-standing relationships, and having them serve as champions who can expand the network that you already have to other like-minded individuals that you already have. And in terms of resources, well, I would say three main sources: personal resources, which is the experience of most of us in LMITs, when looking at personal resources. I'll say we have been a bit fortunate with some grants, and of course, we have a lot of support also from our partners in HIC. Thank you.
Just the two of you living and working in North America, is it any different? Just like what your experiences are, is it any different from what they expect? You somehow to get money to collaborate and stuff like that.
Yeah, okay. I think the challenges are the same in terms of what's the level of commitment from HICs. Is this just an individual project that's been run by somebody who's passionate about it, or is there actually some institutional commitment? And I think it goes back to what Professor said, it's important to realize that we can't base initiatives and projects of just one person or group of people's passion, but they need to be institutionalized. And how do you do that? As we get from TV around, it's not just about the physicians, it's also about the government, it's about the administrators. And so you have to make that value proposition. Why should they support them? What's in it for them? What do they tend to gain from it? And make it, I would say you need to make your mission someone else's vision. So if they see what you're looking, then they buy into it. And then you don't need to be the one pushing it, everybody else is pushing it. But realize that the discussion you have with your fellow physician in an LMIC or HIC is different from the discussion you can have with the administrator. Because you need to speak their language, and you need to speak a language that they understand what's going to be a value proposition for them. When you set that up, you can get more people to buy into it. I totally agree. This can just not be an individual passionate project, because once you don't have that structural support, then it really falls flat with once the individuals are no longer there.
I think the points they've all made on that question quite clear. I don't have any more ways to reply.
Okay, thank you, guys. We'll go to our last question for the session. What about the role of trainees? What part do trainees from either side play in this collaboration? What's their appropriate role? And really, when should they be introduced? Is this early on in the collaboration? Is it once the collaboration is more established? Is there an ideal time for their involvement? What should that look like? Since we're gonna cut a question, I want all four of you guys to kind of answer that if you can.
Okay. I think training can be involved at any point as far as they have the interest and their expectations should be framed and managed. Obviously, you come in, you find some residents who already, some who may have lived in foreign countries or from foreign countries who have some experience. So have an idea of what they are going into. And for other people, it may be adventurous in curiosity. So I think it's important to manage expectations on what exactly they're expecting to receive from such a global surgery import experience. And I think there are scores of people in the audience who can give you all kinds of stories, positive and negative, on the involvement of residents. But I think expectations is important.
I think it's important for trainees to be involved at all levels. They need to know how the source is made. You don't want them in there and just seeing how it's all done, without really realizing what goes into it. Because a lot of the work, I mean, it's easy to say, well, this is all nice, we've said it all out. It's just like you training the surgeon to train the surgeon. If they're just only coming after the patient is correct and the decision is made, then they've missed the whole essence of what's involved. But being involved from the pre-op and the center with global, any global intervention, from just being the bystander, looking at the collaborations, the discussions, the negotiations, the challenges, the things that go through. Because again, that's how you build sustainability. They've learned what you went through. So when it's time to take over, they have a good idea of what that involves. But it's important to set clearly what the level of involvement of the trainers are. Initially, they need to be bystanders. This is not an opportunity for trainers to come and test their skills, try their skills on practice. In other settings where they're not credentialed, they're able to perform at that level. So setting that up is important. But I think being able to have a line of sight to see what's going on along the way is critically important to see how everything got started, so that they can appreciate how it arrived at the level it arrived.
Yeah, I think I just totally agree with what has been said by the previous speakers. It's very important to involve trainees from initiation, execution, and I'll just speak from the research perspective. You know, I think Professor Chia was focusing on clinical aspect. So initiation, execution, implementation, and even auditing at the end of the research, they need to be involved throughout the entire process, and they can serve as collaborators as well of the entire process and well acknowledge what they have done, you know, and then involvement in the process. Thank you.
Well, I agree with everything that has been said, but I'll just give it over in my language. I'm trying to translate it. A masculine mind that does not involve his child in minding that masquerade. When he's gone, his masquerade is dead. That's just it. Even in these our meetings, if our residents don't come for our meetings, which is a problem I've seen in most of these meetings, when they get their fellowship, they won't learn to join us in meetings. Our meetings will be there. Thank you.
So a round of applause for. Right, so for our very last third panel, we're joined by Professor Peter Dokko, who's the consultant in oral and maxillofacial surgery at the Department of Medical Science, Technology and Corporate Teaching Hospital. He's a past president of the Western Faculty of Surgeons, Professor Jean-Marie, Professor of General Surgery at CNHU, HK, Cotonou in Benin. Peter and Claire, who we've introduced already. And last but not least, Dennis, please forgive me, Dennis for here, right? The acute care surgeon and associate professor and director of the Center for Multicultural and Global Health Surgery at the University of Tennessee. And please give them a round of applause.
Thank you all very much. This has been a very fantastic session. I'm hoping that we can talk a little bit more about the next step, which is sort of maintaining these collaborations. We've created them. We've set mutual goals. Now, how do you make sure that you're all on the same page? So the first question that we have for Dr. Gondor and Dr. Eke is ongoing evaluation and refinement. Why is that important? How do you do it? How frequently should it be done?
So thank you very much for the invitation. Let me just make a couple of comments. I think when you look at the global service setup, so usually there's a mindset how the global setup do there. What we forget in this whole equation, especially when we talk about bidirectionality, is what do the global north want from the collaboration? it's something that is never discussed. It's assumed that it's all to help us. But you know, it's important in this whole equation is if the needs of the global north is not never addressed, this whole relation is due to fail. So we have to find out what do they want. There is a possible opportunity to get grants. There's an opportunity to get more publications. There's an opportunity for them to also get greater recognition. These are questions that must be asked. So, of course, on the other side also, the Global South institutions that are involved also we have to say, what are they looking for? Are they looking to have capacity built? I'll give you a small example. When, let's say, these organizations decide or groups decide to join a grant rights, initially, the impetus would be from the north. And then as time goes on, there should be a plan to make Southern partner the lead investigator. Now that is real capacity. If you continue throughout forever and then you, it's always the lead investigator is from the other side and the subordinate investigator is from the south. That capacity to lead and manage a big project is never acquired. So I think these are some of the things that we need to look at. So that's looking at the interests of both sides, that's how you maintain it. Making sure that the youngsters on both sides get to understand the motivators behind the collaboration, and they carry on with the original goals and objectives. So our trainees must appreciate why it all started. And be focused on the goal, be focused on their interests as well as the interests of the other part. This is my first comment. Thank you.
I think a lot of very powerful points have already been made. And I think one of the biggest things when you talk about refinement, the goal of the goal, obtaining the eventual goal, I think the ultimate measure of success is when you can totally withdraw yourself from any project or any collaboration, and not that you don't keep collaborating, but you know, the other party is able to manage it completely. And I think it's also important that some of the very important points that were made, that when we talk about this, you know, global surgery collaborations, the point has been made that these are all already even within this sub-region, for instance, Sierra Leone and Liberia, where obviously not as advanced with medical training as Nigeria and Ghana. And there was that assistance that occurred in many different ways. And you see that Liberia, for instance, was talking about a number, the presentation yesterday, a number of new specialists that they have acquired over the last 10 years since we had a meeting there the last time. So I think that while we kind of are looking at this from, you know, a high income country to a low income country or global north, global south, we also have to think that this also occurs within regions, even within the United States. I think about initiatives even in certain states where surgeons from urban areas are assisting out, like in Michigan, have a very great collaborative when they have surgeons assisting each other in trying to help to develop their surgical skills. So, thank you.
Thank you very much. Very insightful comments. Just a quick follow-up to that. So if you're evaluating and refining the program and seeing that you're meeting your mutual goals, how often do you think that should occur? And should that feedback be anonymous?
I think it will depend on the project, obviously, and I think whether it is anonymous or not would depend on the circumstance. But I think openness is always a very, very good policy.
how often, as often as is needed. And but at least you should aim to have an evaluation once every year. How open must be very open. And I think when you learn to open up to each other, it goes to just strengthen the collaboration. We talk about the difficult issues, from the challenges. I can give you several examples. Time will not allow, but there are many occasions where you have to talk about. I mean, there was a case where we needed to renew a grant that we've been associated with for years, almost like 10 years. And then we looked at the power structure and the way the grant is set up. And then we said, no, we're not going to go forward with this unless something changes. And we had a very difficult conversation. Ultimately, the others saw it from our perspective, and the change actually was effective. So it's doing very well. Everybody is still gaining out of the grant, but then got to a point where those at the asset center said, we can run it. And you have a look at every stage, every step of the way. So yeah, I think long conversation on that. And sometimes the review might be triggered by, so it's not 1 year, a problem arises. Thank you, Lord.
Right. My next set of questions to Dr. Lorentobi and Dr. Astoria. Now, what strategies have you found effective in building and enhancing local surgical capacities within the LMICs and the partnerships? Would like to invest.
Okay. Okay. I want to understand the question with slowly. Okay, because I'm coming from.
I understand. So what have you found useful? What have you found useful when you have to build local capacity? That is, help your surgeons to improve under these global surgery. Or what has been helpful to you in building this capacity?
Yes, thank you. We say that we have to increase the number of trainees in surgery. And like we have to increase this number of surgeons, we can find the simulation. Simulation is very important to practice more and to practice well before going to patients. But we didn't have enough simulation center in West Africa, Latin America, Benin. And we are trying to set it on the simulation training of the simulation training center in the capital, in the faculty of medicine. But I think that most of the hospital center have to put on a simulation center. When every center where there is surgery have to set on the simulation center to perform better surgery.
So he's talked about a low-hanging fruit which can be set up in various places. Talking about simulation and improving the skills of our trainees and perhaps even the trained who should not be trained well enough. Better to go along.
Yeah, so I think when we think of local capacity or in-country capacity strengthening, I think this conversation here is being framed as partnership between institutions. And the nature of the institutions in the partnership obviously varies tremendously. But if you think of it as universities or global north universities partnering with global south universities or global south hospitals. So I think there are those frameworks, but obviously we know that there are lots of non-profit organizations that are involved in these partnerships. So the partnerships are very varied. how you nurture that, how you maintain those relationships from a capacity building perspective, I think comes first as to how the relationships, sprouted, and then, do you all have a formal MOU? What are the mechanisms that have been put in place? Does it call for strengthening capacity in research, in education, clinical care? Is it broad across across the different various pillars? And what stage are you in that implementation? Now, when I think of maintaining, a relationship, I think Dr. Oyetule mentioned before, you have to be able to, we all work for someone. Somebody is our boss, whether it's the university president or it's our hospital executive, whoever that is. To maintain this relationship, you have to be able to talk to them very well and know how they feel and what they will consider as success. Because what they consider as success would really determine, what you can do. What would they say at the annual meeting to their board of trustees about your program? And what would your partners say to their, executives about the partnership? So I think that's something that has to be very clear. When we look at local capacity building, I look at it as the priorities that the institutions have identified. Is it research capacity, as one of our colleagues, said earlier? And if that's the case, how are we doing with that? And how are we ensuring that what Professor Donko mentioned actually happens, where HIC investigators are not continuously being the PI on research projects? So I think that has to be a very, formal, very frank conversation that's had. One thing that I think we also tend to forget, and I have this very acutely in the back of my mind, is because I have had projects, I'm from Cameroon, and I have had projects where our team in Cameroon deals with Cameroonians in high-income countries, and they treat them with a lot of deference, with a lot of deference. And most of the time, folks don't speak up because there's the colloquial saying that I don't want to put sansan, I don't want to put sand in someone's food, something like that. So they don't want to do that. So that aspect of being very clear, very clear with your in-country collaborators is extremely important. Because if your in-country collaborators cannot tell you, it's not working, then it's like they cannot really frankly tell you that this collaboration is not working with them, then I don't think that trust that, Dr. Price said earlier has been established. It has to be very frank, where your friends have to be able to tell you the sad truths, the hard truths. So, and I think that's where it goes. The other things regarding capacity building, I think it's easier to do when there's that real mutual understanding and we know what success looks like for all the different, leaders in the system.
Thank you very much for that. Once again, theme of relationship building and communication. We're going to shift gears a little bit to our next question, and this is for Dr. Oyetole and Dr. Eke. But knowing the goal is to achieve a joint product, what issues have you encountered in producing outcomes from your collaborations? And are they truly joint? So you want to produce things jointly, how has that gone?
So your question is, what kind of challenges have we encountered when trying to have some common goals
A joint product, whether it's a publication, whether it's a grant, so how have you made sure that that is equitable?
Yeah. One thing I have thought about, one thing I can think about very clearly is, over the last few years, trying to help to develop the ATLS programs in Nigeria and further. And I think that the most important thing has been trying to listen to partners on the ground and moving at the pace that they feel that they can move at, because they understand the local problems far more than I do. Even though sometimes I think I do, but I realize because I don't live there, I don't, and the landscape is constantly changing. Personally, I don't think I have encountered a lot of issues because thankfully I've come to understand really deferring to those individuals and not trying to push too hard and moving at a pace and, facing the obstacles as they come.
Thank you. I'm sorry for my English. Okay. I always think that surgery must be inspired by soccer. You say soccer from Africa, it's a playing country in north, the north, in UK, in France, and they are very brilliant. And when they came in the country, they came back to the country, they developed the country, they developed and inspire also people to be very good players. And I think that if what I expected, that we have to set ground to the training center in Africa. The training center must be very encouraged by money to try to make many more trainees. Some will go to North, stay there, but some will came back and inspire the other people. That's why I think that the partnership will be give more money to the training center in Africa.
I think we have reached the penultimate part. We've reached our last set of questions, and they're going to, I think, to Dr. Peretta and Dr. Longo. How have these things impacted on career advancements on both sides of the divide? These collaborations.
Let me start with a few examples. As I said, we've been involved in a lot of research grants. And as a result of that, many of the young people who have been mentored then have become independent grantees of the NIH, for example, the one grants. And that is benefiting. The other partners, trainees, have also gone on to win NIH grants. We've always made sure that both parties benefit. The other way that I'm involved with has also been with, especially technical part, where we constantly engage with the partners. We're supported by this NGO, Smart Trade, who are focused mainly on local or supporting local partners, which I believe is more sustainable long term. And so through that, West Africa Project Center is actually currently training young surgeons in cleft surgery. Every year we train between 6 and 8 young surgeons who go on to practice cleft surgery. How does it help Smart Trade its objectives? To able to convince its donors that these are the great work that we are doing. So it's a win-win for us. So these are just 2 examples. Thank you.
Second all of that. I think also one of the points that Prof. Donko mentioned earlier is that partnerships from the North have a lot of value for the North. A lot of it that folks in LMICs may not readily identify or grasp, but let's be very fair and frank that it's not charity work. There are interests, there are goals for institutions, for individuals, whether it is standing in NIH for different institutions for the grants that they get. There are community or the board of governors or the board of visitors of each institution. So there are real wins that institutions and individuals have. And HIC partners who are engaged in global surgery work have seen a lot of career advancements, a lot of visibility, but also to ensure that in-country partners have the visibility, and we see that across the board in ensuring that quality improvement programs and projects that in-country partners undertake becomes very visible, and they can deliver on that, and it leads to their own career advancement, whether within the ministries of health or within the surgical society in the country. So most of these endeavors tend to lead to career advancement for the collaborating physicians and also for really the trainees and the students who are engaged in this process. So it's a very bi-directional win. It has to be made very equitable, and I think being very frank at the outset regarding all the potential benefits and the areas of interest is key to any successful long-term engagement.
In the last section for everybody all the way around, and it's how to make authorship equitable to all of your partners. How do you do that? I guess part of it have been addressed already, but let's get a formal answer. Yeah, so obviously it just needs to go according to the dictum of any publication. Whoever you have to determine who is the first, who is the last author, and everybody get the appropriate amount of contributions that they contributed. So I think it's just common sense, just make it equitable.
Saying that is for the paper publication, yes, in the French country we have many problems because most of the publications are in English, and even in France, we want to make some publication in English, and something when I go to the conference in France, it's in English. Now, and I know that is why I told my students, try to be very good in English if you want to make a good publication. Yes, it's why for the first level, I think that in the French-speaking country like us, we have to begin to make a good English. Maybe to have someone who can translate the French in a very good English, because if it's Google translation, you say that's very good mistake.
I think for any collaboration, this is a very key point for every collaboration, because I think there are knowledge gaps in this area. Knowledge gaps in, first of all, the different authorship positions. So I think in these conversations, so partners across the board, not high income, low income countries, I think there has to be a very clear discussion within teams for each project regarding what constitutes what level of contribution. So LMIC colleagues are not left in the dark, and also what tends to happen where people have contributed in different ways and they are not happy regarding where they find themselves in the publication or if they don't make the publication. So I think it has to be very clear from the very beginning regarding what kind of contribution is expected specifically, and for co-authorship in order for you to be there, and the amount of work that's required for that to happen. Obviously, even when this is set up at the outset, because of whatever reasons, there are still at times when folks don't live up to that, and it has to be, at least my view is that it has to be very clear regarding when someone will lose the opportunity to, to lead that. For example, if you're going to be first order on the paper and then you're not producing, then the time comes where you have to be cut off to have someone who is going to be able to lead that. But I think the goal should be to continue to build a process where in-country collaborators, have the research experience to be able to drive that process forward.
So thank you. I think I agree with everything my colleagues have said. We all also notice that high income collaborators are very good at writing. And so that's a gap that we seek to address early from the outset by organizing manuscript writing workshops and just like that. At this conference, we are co-hosting a program on converting your thesis to publication courses for trainees on this. And so it's a problem that must be addressed. We must teach people how to write. And then the position of the paper, there are so many nuances. In some places, being first is important. Being last is for the big group. So the different positions have different ratings. I think all these must be discussed, as my colleague Ben has said. And it's just, but you must work gradually and systematically to make sure that everybody is happy. And that they get a position that they deserve based on their contribution. So this is my comment on this. It is one of the areas of conflict. It may even happen that having agreed among yourselves, some name appears on the paper that you didn't know about. It's from the other side. There may be some challenges on that side of the collaboration that require that the person's name be set. With this all must be discussed. If applications when people have requested that their names be added or taken out, and so these are all issues that continually deliberate upon through communication, constant communication as a way of maintaining an effective collaboration. Thank you very much.
I want to thank our panel, so let's give them another round. So that concludes our panel session, but we have some few minutes for questions from the audience. And I'll ask that our current panelists just stay up for any questions. And then we will also be joined by any of the remaining panelists who are here. I know there are other sessions happening, so a few of our panelists have to leave. So are there questions from the audience?
I just wanted to make a comment. One of the, what authorship are you there? I think the key is to involve the person on the ground in sub-Saharan Africa at the outset, not at the back end. Actually, that's what the international medical journals mandate. And I think if you write the paper and then just stick them on there somewhere, somebody talked about encouraged to be caught in the middle. But I think we need to involve the folks on the outset. Two other comments based off the Lancet Commission, other things, relationships. I think that's really critical. And then you presented a paper that was written by Ali Device and Charles Mock that was from the ASA white paper. I think that it's an analyst paper for like 2020. I think that's very good. It gives 6 examples of successful partnerships. And the two that I would highlight is what Charles Mock has done with his colleagues in Ghana, in the sense that he has trained people that are writing their own grants, their own research. And then in the T. Peter Kingdom, worked with Al-Sisi, in the Ife has done the same thing with colorectal surgeons. So I go back to the New Testament, and there was a guy named John said, "They must increase, I must decrease." Thank you.
Maybe you can look them up. I don't think our close like that one.
Eric, thank you for the conversations and audience. Thank you for the comments for a very interesting discussion. I just want to make a comments or a suggestion. Our institution has been partnering with the College of Surgeons Center of Southern Africa for 17 years now. It's like recognized the president here, who correct me if I say anything wrong about this. One suggestion that I think addresses some of the challenges that have been raised by the panel is around governance. So our collaboration is governed by a steering committee with 50% nominated representatives from OCSI and 50% nominated by COSEXA. I didn't address a lot of the issues. The people who were involved in setting up the collaboration, too, many people have since passed away, and not a single individual still remains involved in leadership of the collaboration from the start in 2007. It's changed, which is, to me, a sign of success. I think it's a sign of moving from the personal, everything felt personal, but if it doesn't become institutional, then it doesn't fade away. So I think that's an important point. And another thing, your colleague raised around the finance. In most cases, it is the high partner who maybe holds the grant or receives the grant. But what happens then? So our steering committee, we build a 4-year plan that every item is costed. Those items that are more appropriately spent in the loan sort of setting go to COSEXA. That funding goes. There's an on-granting agreement, a legal agreement, and they look after that funding. We look after the funding that's more appropriately spent from our institutions then. So let's do calls. Other questions?
Thank you. I'm Katie from Lightfox. And my question to the panel, it's quite noticeable that massive growth of global surgery programs in high-income countries, but that's the symptom of the structures that have been referenced and the history that have been referenced. So what's happening around building those same programs in low-income countries? I know about University of Global Health Equity is a really good example, but what else is going on in that sphere?
Anybody want to take that?
So, global health is targeting, essentially aimed for LMICs as states. One of my colleagues once said, what those in the high-income countries describe as global health or global surgery is what we do every day. So for us, it's everyday surgery, everyday health. So I think our challenges must be seen in the broader context of health. Is what are our priorities, our prime challenges, and how can we best address them? But in this case, with the help of our colleagues, high income group, this is how I see global surgery, the conversation. Establishing programs of global surgery sound good. The question is, can we isolate any problems and make them our prime focus currently? The changing neurosurgery, Christina is going to be pediatrics. That will allow me to trauma surgery. I'm focusing on other things. So, but all these are important. So I think it's we just have to try to say that let's identify broken phase and harness support from elsewhere. That's how I see, rather than establish real specific programs targeting say all the global saving programs. I don't think that's true.
I'm sorry.
You said it all. Okay, I think we have time for one last question.
Thank you. This was a wonderful session. I mean, I think all the points have been raised. I just want to make a comment on how important the initiative part is, which always starts with peer-to-peer friends, and particularly for us from the diaspora coming home and trying to get something started. I just want to bring the point that for us, for every one successful collaboration we created, there is probably about 5 or 10 that did not move to the next level. And I think there is great
to be taken by everybody. And sometimes it's that diaspora who came from the high income country wanting part of this environment. So I think this conversations need to continue, and I think this is really an important topic that might ignite and the understanding. And I really appreciate what you say about we need to have clarity about what do the high income country partners want. And that needs to be on the table. Otherwise, that partnership, that mutual benefit will not be clear and you can't develop it more. So I just want to appreciate that.
Okay, I think that brings us to the end of our session. There are a few links with information up here if you want to scan it with your phone that I showed earlier. One talks about the committee work the AAGS does and what the specific goals of each committee are, and the other is a link to be able to join the AAGS. And of course, please don't forget to check out our website and follow us. We are on Twitter, Instagram, everything else. We also have an amazing YouTube channel with much of our content that's available. And if you want to say hello to us, want to send us any ideas, tell us what you'd like to see the AAGS tackle, or just need to get in touch with us for something, please email us at the email that's at the top of the slide. Thanks everyone for joining, and thanks our panelists for an excellent session.
You know, I don't.